So, hello and welcome to our talk tonight, What's Making Us Sneeze and Wheeze. We really appreciate you spending the time to be with us tonight. My name is Fiona Ewing and I'm the Community Engagement and Events Officer for the Menzies Institute for Medical Research. I'm going to be your technical host for the evening. We've already had a few technical glitches, but I'm sure we'll be fine. So we're going to begin our presentations shortly, but I just wanted to let you know how the evening will go. We had organised for the Director of the Menzies Institute for Medical Research to give our introductions tonight, but unfortunately she's just sent me a quick email saying she's having, oh no, she's here. Okay, fantastic, great, Alison. Okay. All right, just a few housekeeping notes before this evening presentation gets underway. And so we do encourage questions, but you'll notice at the bottom of the screen that you have a Q&A button, and this is how we would love for you to ask questions this evening. This is so we're not interrupting our presenters as we go, and we can all keep to the timeline so we don't go way over time. But we do certainly encourage you to submit any questions during the course of the webinar, and they will stay in the Q&A function. So at the end of the evening, when you log out of the webinar, you'll be redirected to a short survey aiming at improving the webinar experience for our future online guests. So we would really appreciate it if you're able to find a couple of minutes to complete the survey. For those of you who engage with Twitter, our communications manager will be live tweeting during the talk, and the Twitter handle is @ResearchMenzies. The last thing I need you to know is that this webinar is being recorded. I think you would have been advised when you popped into the webinar. So this webinar is being recorded and it will be available later on a later date on our YouTube channel. So now it's over to the Director of the Menzies Institute for Medical Research, Distinguished Professor Venn, Alison Venn.
Yeah, thanks, Fiona. And look, good evening, everyone. So as Fiona said, I'm Alison Venn. I'm the Director of the Menzies Institute for Medical Research, and I'd really like to warmly welcome you to our public talk presented for the second time as a webinar. And as a reflection of this institution's recognition of the deep history and culture of this island, the University of Tasmania wishes to acknowledge the Muwinina and Palawa people, the traditional owners and custodians of the land upon which we meet. As a short introduction to Menzies and the work that we do, we'd really like to just show you a short video that I think captures our intentions really effectively.
Please stand if you, someone you love, or someone you know has been affected by multiple sclerosis, dementia, arthritis, heart disease, or cancer.
So really we are very committed to doing research on the diseases and the health conditions that affect every Tasmanian or someone in their family or a loved one. Today's public talk via a webinar is a different approach for us. We appreciate that it presents some challenges and it isn't ideal for everyone, but we wanted to make sure that we could still offer a public talk despite the restrictions that we all have on gatherings. And we hope that you enjoy it, and we will certainly welcome your feedback. Like many others in Tasmania, at Menzies we've mostly been working at home, but our researchers have remained very committed to their research and finding ways to ensure that we keep it going. And while medical research is very much front of mind in relation to COVID-19, it's really crucial that we continue to focus on other aspects of our health. So today's focus, what's making us sneeze and wheeze, is on how air quality affects our health, including through smoke pollution and airborne particles such as pollens. And today you'll hear about a couple of really great examples of research that's been making a difference, the success story of the AirRater app, a really tangible example of how research helps and reaches the community, and also the work that this team has done in relation to the impacts of bushfire smoke. And that's had a lot of coverage in the media and has been behind some of the evidence that's been presented to the Royal Commission. So these are great examples of work at Menzies that we really strive to make relevant locally, nationally and internationally as well. So I'm really pleased to introduce our three speakers this evening. First of all, Associate Professor Faye Johnston. After an initial career in remote medical practice, Faye shifted her focus to epidemiology, public health and environmental health research. And she leads an interdisciplinary research group at Menzies addressing the environmental determinants of health. Our second speaker is Dr. Penny Jones. Penny is a research fellow in environmental health at Menzies as well. She has a very varied background, combining government experience in environmental policy with research spanning paleoecology, which I didn't even know existed until Penny came to work for us, archaeology, aerobiology, and most recently environmental health. And last we have Anthony Flynn. Anthony is the Senior Manager of Research, Policy and Advocacy at Asthma Australia, and he's responsible for the coordination of the National Asthma Research Programme, as well as advocacy initiatives aimed at influencing environmental factors in favour of people with asthma. We really appreciate it when partners from non-government organisations such as Asthma Australia join us for public talks like this. So thank you, Anthony. So with no further ado, I think we should hand over to the speakers, and to start, it's Faye Johnston. Thank you, Faye.
Yeah, thanks, Alison. Lovely to be here and welcome everyone. I will share my screen if I can find the aha, and then I'll get going. Okay, I believe I have successfully shared the screen. So thanks very much, and I'll get started. The theme for this evening is sneezing and wheezing, and you're going to hear different takes on that from the three of us. And I'll confess up front, I'm going to divert. I'm going to include sneezing and wheezing and a bit more besides. Now let me, there we go. Just get my systems worked out. So I head the Environmental Health Research Group, and we spend an awful lot of time thinking about what's in the air and thinking about how it affects our health. And we think about everyday exposures in our lives, like smoke and dust and cold, even cold air, dry air, allergens, chemicals. One we've been getting a lot of lately is hand sanitizer, that you get the fumes whenever you do your hands, which is quite common nowadays. Vehicle exhaust, all sorts of things. And some of these are everyday and some come in big wallops, and the extreme events aren't everyday, but bushfires are one of the ones that is frequent enough that we need to understand it. And of course, the last summer was huge in that regard. So I'm actually going to talk about some work we did on last summer's bushfires that was presented at the Royal Commission, and then Penny will talk more about everyday plant pollens in the air, and Anthony will bring us back to the summer fire event. So for me to get started, just briefly, all Australians live with bushfire smoke, and it's a skill we're going to have to get better and better at as fire seasons get longer and the climate gets hotter and ignitions and people in the bush get more frequent. In the tropical north, we get fires all through our winter or the dry season up there. There is a fire in the photo on the left, it's hard to see. But in fact, Darwin is under a cloud of smoke most dry seasons for several months, a bit like Tasmania and winter wood smoke. And then in the south, we get intermittent. We get the planned burns, we get regen burns sometimes, and every so often we get something more major, usually every few years, with a severe bushfire. And what I'm going to present to you now is a health impact assessment of the impacts that we're able to estimate from last summer's fire season. And I want to highlight Nicholas Borges, our PhD student who did this work, and he's done a lot of fantastic work on the health impacts of bushfire smoke. So last summer, as you all know, was unusually severe season for bushfires, and we had lots of smoke affecting lots of people, and this is how it looked on some days from satellites. The top photo is a simple satellite image over New South Wales and Lower Queensland showing the plumes of smoke. The other image, you can just see the curvature of the earth, which is actually an even more distant photo, and you can see how the smoke went into these enormous wave-like patterns that circumnavigated the globe more than once and caused exceedances of air quality standards in New Zealand. So even by our standards, living with smoke, it was an extreme event. And on the ground on some extreme days, this photo will be familiar to you, but this is in the middle of the day, in the middle of the sun. It's reminiscent of the fogs of London, when at times it was pitch black like midnight in the middle of the day. So it's important to understand, as you know, there have been 3 inquiries and royal commissions into these severe events, and to contribute to that, we needed to have a way of working out what the impacts were, but how can we work them out if we haven't got time to do research studies between January, when these events were happening, and then March, April, when the inquiries were happening. And there's a technique commonly used in this circumstance called a health impact assessment. Because to wait, the real way, and what is very important and what is happening, is that we do the research and we actually look at the numbers of people affected, and we look at their symptoms and whether they went to hospital and the number of deaths. And that's usually a process that takes years for the approvals and to get the data and to clean the data and to work it out. But to know what's going on in a timely way to inform our policymakers, the route that we go down is called a health impact assessment. And that's what I'm going to share with you, Nico's work doing the health and economic impact assessment. And it's actually very straightforward. It's 4 simple steps, but you'd have to know what you're doing and understand smoke and fire and understand an awful lot of the literature before you can do it. But basically the steps are: you figure out the smoke exposure, you figure out how many people got exposed to the smoke and for how long and how severe it was, and you have to know a bit about how often those people would go to hospital or what the death rates were in the different communities, but that information is available. You apply a known relationship between air pollution and a health outcome, and that's where you're a bit constrained because you can only use what's been really well studied and what you're confident of, and that's not every last impact that smoke drives. And then finally, when you've got an estimated number of cases, you can use established and agreed values to put it into an economic figure, which is a useful way of comparing different impacts of a disaster in a common unit. So to walk through those steps, here's 4 maps of Australia, and the top left shows the area burned. They're the red bits, and focusing, not including the tropical north because it's a different system of fires and not so many people live up there. But the severe summer bushfires are highlighted in red, and you can see the eastern seaboard down there is the area most affected. And if you look at the top right, which is Australia's population density, you can see the incredible match between where the fires were burning and where most of our population live. And then going down to the bottom 2 figures, the blue dots are where the air quality stations are, and they tend to be clustered where the people are. And then bottom right is the statistical areas that were included in the analysis. And they were chosen because they had air quality monitors in them or very close to them. So we studied 90% of the population lives in these areas coloured black in the bottom right picture. And most of them were quite close to an air quality monitor or close enough for this purpose. So we've got a sense of where the people are and how much smoke there was, by taking the air quality data from all the monitors, from all the EPAs around the country. And you can draw a line like this. And this starts in October and it goes through to March, October last year to March this year. And the line and this is a line showing the amount of pollution in terms of suspended small particles from bushfires. So it's not our background air quality. Our background air quality is excellent. It's, around 5. over and above 5 due to bushfires is this blue line. So you can see early on that's at 0 because across 90% of the population there wasn't a lot of additional smoke. And then you can see as the season went on in waves, it got bigger and bigger. And on this day, to have the average exposure being 100, which is way above background, that means in some places like Canberra, it was 1,000. So it went on for months, and in some places it was extreme. So what outcomes did we evaluate? And it was these 4 conditions. And this is because these are the ones where we're very confident of the relationship between the fine particles from smoke and the outcomes. So admissions to hospital for heart-related problems, lung-related problems, emergency department attendances for asthma, and premature deaths. And roughly they go up, apart from asthma, about 1% for each 10-unit rise. So if our background is 0 and then it goes up to 20 or goes up to 100, you'd expect 1 extra case. Asthma, emergency apartments, a lot more. Asthma is, as we'll hear, very sensitive to smoke, and it doesn't take much smoke. A little tiny rise can have a major impact on a person with asthma. And then the values, the standard values used in hospital funding for the hospital admissions and emergency attendances. Mortality has a value of a statistical life. You can have endless arguments about how one values life, but this is a standard figure that's used, and it's useful to compare across seasons and compare across other outcomes. And I won't go into the complexities of how people come at this. A comment about the deaths with smoke. It's often, lung disease is often what causes the immediate problems that people see and feel straight away. When it comes to death, it's actually more commonly things like heart attacks that get precipitated by smoke. Not always, it's both, of course, but it's usually people already very at high risk of a heart attack for all sorts of other reasons, and then the smoke is the trigger that causes that. Or the smoke has triggered a severe respiratory decline in an illness, and that has led to death. They're the pathways. It's very uncommon. On a moderate smoky day, it might be 1 in a million people. But when there's a lot of smoke for a long time, it can add up. And that's what I'll show you in a moment. And just a quick note, there's all sorts of other impacts that smoke causes that aren't a part of this, because we didn't have the confidence and in the multiplier that you might use to figure this out. It's different in different communities, and there's just not been enough studies done that we're able to model this. So this table shows the results we got and the costs that we estimated for it. So we've done, and some of this was published and some presented, this number for 429 premature deaths is our current best estimate. It's always been around that amount, a bit over 400. And that seems like a lot, and it is a lot, particularly when you put it in the context of the estimated 33 who died in a direct encounter with flames or accidents related to firefighting. The reason it's so high is because so many people, like at some stage, 80% of Australia's population got smoke from a fire. That's millions and millions of people. And that's why it all adds up. And it wasn't only such a huge amount of people, it was going on, and it all adds up day after day. You know, an extra few deaths on one day and another day and another day. And when it all adds up, you get to quite a big figure. And similarly for the admissions to hospital for heart and lung diseases. And highlight here, asthma, it was about 1,500 additional cases that wouldn't have happened without the smoke that we estimated, additional presentations to an emergency department. And that, of course, is the more severe end. It's not all the people who had worsening of their condition without needing to go to hospital. And adding up all the figures, we're getting somewhere approaching $2 billion, mostly driven by the mortality estimate. But still, that's a large impact and on a par with all the other impacts with, you know, firefighting, loss of housing, loss of property that were associated with the fires. But there is a bit of a counterintuitive point I want to make, and that is that most of the impacts, and we actually calculated this statistically, and it was 80% of them happened on days, and if you look at the horizon, the vague haze, it was on days when the smoke might have been around the air quality standard, it might have been above the air quality standard, up to, if you're familiar with the measurement, up to 50, which is twice our air quality standard. 80% of those deaths and asthma presentations happened on those moderately impacted days rather than the severely impacted days. So the severe impacts cause a lot of anxiety. They're terrible. The photos are amazing to show, but actually the huge public health impact is more the fact that so many people were affected and it went on for so long, grumbling away. It's like a little bit of extra smoke going on adds up to a bigger impact than the odd extreme day, which is a reason we have to take all sources of smoke and all sources of air pollution seriously. There's no safe lower level. As smoke creeps up, health impacts creep up. And in fact, when you get to hazardous and 10 times hazardous, at a point it probably levels off and there's probably not so much difference or additional harm when you get to those extreme levels. And just to finish off, to show you the last 20 summer fire seasons and the cumulative health costs day by day. So we're going from October day 0 to the end of March day 180. And day by day, you can do these calculations of the excess pollution from bushfire smoke, and it creeps up during summer. And usually it's less than 200 million by the end of the fire season. There's a few fire seasons, particularly those where the fire season starts early, that the smoke impacts caused extreme events. And until this last fire season, the 2002 to 2003 was our most extreme event. But just to show you how dramatically different last season was compared to the previous 20 seasons, the last season here is shown in red, and that's approaching 2 billion. And this next figure actually shows the same thing by state and shows you the most populous states. New South Wales, Victoria and Queensland were the ones that bore the brunt of this. So what we've got is a ballpark estimate, because the rigorous studies are going to take time, but a consistent approach does enable us to compare. So it's useful, but remember it's an estimate, it's not the absolute truth, but it gives us an idea of the kind of impacts. And I think I went, yeah, sorry, I skipped over a slide. So just finally, it was an unprecedented season with serious impacts. The point I want to make is we need to get good at living with all smoke, regardless of concentrations. We've got a lot of smoke in Tassie from our wood heaters, and that goes on and on for months, and that has seriously concerning impacts as well. Excuse me. And so working at understanding and living with smoke is one thing, and working at mitigating climate change. We're in a period of rapid environmental change. Life is going to get smokier and smokier, there's no doubt about that. And working to mitigate the climate change is equally as important as working on how we live with it and using air filters and various other strategies. They're both where we need to go. So thank you. I'll end it there. Actually, I think questions are at the end. I think Fee will tell you that. I'll leave it here and hand on to Penny for stage 2. Thanks, Penny. Can you unmute, Penny? I can't hear you.
Excellent. There we go. Here we go. Unmuted now. All right. So thank you very much, Faye. So as you can probably tell from my slide, and as Alison mentioned before, I'm going to provide, if you like, the light relief between the bushfire smoke disaster stories. And I'm going to talk about pollen, which, look, it also causes its problems, but at least it looks quite pretty down the microscope, which hopefully you'll agree after some of my slides. And I'm going to talk about some of the research that we've been doing here at Menzies using the AirRater smartphone app that our team, led by Faye, run to discover which types of pollen exactly are making us sneeze and wheeze. So There we go. But first, a little bit of a reality check. So asthma and allergies, probably to a lesser extent asthma, but certainly allergies can be a little bit of a poor cousin sometimes in the medical research world, sometimes compared to things like cancer and heart disease and stroke and things like that. There can be a bit of tendency to say, oh, well, look, bit of hay fever, what's the problem? But actually, asthma and allergies together affect millions of Australians. Australia has some of the highest rates of both of these conditions in the world, and Tasmania actually has some of the highest rates in turn in Australia. Across Australia, about 20% of people, so 1 in 5, have hay fever, and about 1 in 9 or 11% have asthma. And when you consider that both of these are chronic conditions that it can affect people for many, many, many years on a day-to-day basis, again, those impacts do really start to add up, as you can see from a few of these stats here. So if we can do things to try and minimise the impacts of these conditions on those people who suffer from them, then absolutely that's something that's worth getting out and doing. And we know that pollen is often one of the triggers, and that actually goes for both asthma and hay fever. It's certainly not the only thing that triggers asthma. Obviously, bushfire smoke can also be an important trigger for asthma, all sorts of other things such as dust mite exposure, fungal spores, exercise, things like that can trigger asthma too. But pollen is actually an important asthma trigger as well. And some of you might remember the thunderstorm asthma event in Melbourne in 2016, which was caused by a combination of grass pollen and a particular type of thunderstorm. And that certainly really starkly illustrated that there can often be a link between pollen and asthma, as well as the hay fever that we more commonly recognise. So that's great. So we might know, okay, well, maybe it's important for us to try and minimise people's exposure to pollen and to help them do things about managing that. But there are actually lots of different types of pollen out there, and not everyone is allergic to the same types, and certainly not all types of pollen. So if we're going to help people manage their hay fever and or pollen associated asthma symptoms, we really need to know which ones matter. And that applies both at an individual and also at a population scale. And in Australia, certainly in southern Australia, such as Tasmania, we certainly know that the usual suspects, if you like, include grass pollen and also birch, the silver birch trees that are quite common in parks and older-fashioned gardens. And absolutely, we definitely know that both of these pollen types are certainly really important. Grass pollen, as I mentioned, was one of the triggers for that thunderstorm asthma event, and birch pollen is certainly a very important asthma and allergy trigger. But through our research using the AirRater app, we've discovered that perhaps this might not actually be the full story. Perhaps there might actually be some triggers out there that are less commonly recognised, both at a clinical level and also at a population or a public health scale. So just to introduce the AirRater app very briefly, so this was an app that was developed by Faye and a team in 2015, and it's a smartphone app coupled with a data collection network that provides people with local and close to real-time information on pollen, air quality, so smoke pollution, temperature and planned burn locations. You can also enter your health symptoms into the app, and then you can learn what you personally respond to, which, as I mentioned, is actually different for lots of different people. And you can also receive alerts when those environmental triggers are present. And the aim for that is to help people to better manage their health, so they know when they might need to take action, such as if you're asthmatic, taking your preventative medication, closing your windows, making sure you don't exercise outdoors, all those sorts of things that really can make quite a big difference to your quality of life and the extent to which you get symptoms. We started off in Tassie. We're actually now national, really exploded over the summer period, which was quite busy for us all, but started back here in Tassie in 2015. And I'm really just going to talk about AirRater in Tasmania today. And so while AirRater, as I've described, is absolutely primarily a function to help people, particularly with asthma and allergies in the community, better manage their health, it's actually also really useful from a research perspective. Because if people are logging their symptoms, that gives us information on when people are having symptoms across the community, and then we can match that up with the environmental data that we also have about that place and that time. And we can put all of that information together and get a sense of, at a population level, as well as an individual level, what exactly is driving asthma and allergy symptoms. So that's what we've done. And as I said, we've just looked at the Tasmanian data for the time being, because that's where we've been operating for the longest period. And so we've got the most data to work with to be confident about the results that we're getting. Hopefully aiming to look at Canberra later this year, but so far we're just looking at. So we put all of that symptom and environmental data into the mix and modelled it to see, okay, so what seems to be driving asthma and allergy symptoms in Tasmania? And we found a few surprises. Look, we did also find the nice comforting things that you'd expect to find, such as an association between smoke pollution and asthma symptoms, for example, and that grass pollen and birch pollen seem to be important triggers. And it's always nicer as a researcher when you find out what you think you should find. But we also found a few surprises along the way. So these 5 seem to be Tasmania's top pollen culprits. We've got grass and birch, which we met before. We've got the cypress family, and that includes the sort of introduced conifers that you see in many gardens, but also there's actually quite a lot of Tasmania's native pines are also in the cypress family, and they all produce the same type of pollen, and lots of it. We've actually been getting extreme pollen counts in Hobart lately, and that's been due to cypress family pollen. And then we found eucalypts and the sticky hotbush, which the budding botanists out there might know as Dodonaea viscosa. It's one of those really innocuous sort of shrubby trees that actually is everywhere through the dry eucalypt forest around Hobart, and actually also across a lot of Australia. But it's a type of tree that it's a little bit nondescript, and you probably wouldn't really notice it unless you went looking for it. So that's what the hotbush is. And while those first 3 weren't really surprises, grass and birch I've talked about, cypresses are known across the Northern Hemisphere to be really important asthma and allergy triggers. Those last 2, the eucalypts and the sticky hotbush, were slightly more surprising, particularly the hotbush. Eucalypt, there's been a few studies, including one that faded up in Darwin about 15 years ago, that have found associations between eucalypt pollen and allergies. But no one's really ever taken it all that seriously or looked into it. And so it's still not something that's really commonly thought of as an allergy trigger. And Dodonaea, that sticky hotbush, no one's ever really proposed that as an allergy trigger before. So that was quite exciting when we found that. And that's a close-up of the Dodonaea flowers, which are actually quite beautiful when you get close up. But this all made us stop and think, okay, well, that's great. So we know that birch and grass and cypresses and things like that are important, but maybe looking at this data, perhaps we're actually missing things out there. Perhaps there are things that we might need to be testing people for or warning people about. Maybe don't go and plant it in your backyard or through the school playground that we're missing at the moment that we don't really see. But we did want to be a little bit cautious, and that's just because AirRater, as I said, it's primarily a community service rather than a really controlled research study. We're crowdsourcing that symptom data essentially from all of the thousands of people out there who are using the app. And while we do have a lot of reasons to think that data is useful, and we're getting more and more confident of that, it also does mean that data is a lot more messy than medical researchers really usually like. People might use the app for a few months and then stop, or some people might log their symptoms every day, some people might only remember to do it once every 6 months. So it was a little bit messy. And so we wanted to be confident that actually these associations with eucalypts and the hotbush we were seeing are real. And we have actually gone and done some more analysis with AirRater data, taking an extra year's worth of data and using a new method that we've been using in collaboration with a professor in the UK that's specifically designed to handle this really messy smartphone app-based data. And we're getting pretty much the same results. So that again suggests that, yes, actually these associations that we're seeing are actually real. But before we go and shout this off the mountaintops and tell everyone that these are really important new allergens that we've discovered, we do really want to make sure that these associations are correct. And that's where the Witch Pollen Project comes in. And this project was made possible by funding from the Tasmanian Community Fund. And we're using a few different methods together to really directly test which pollen types are causing hay fever in Hobart. And we're doing that by combining AirRater with immunology, both the type of skin prick test, which is a type of diagnostic test that you might get if you go to an allergy specialist to test what you're allergic to, and also a new and very novel type of blood test, which if you're a pollen nerd like me, I think it's fantastic. It's great fun because this type of blood test, as I'll show you a little bit later, you end up with pollen with purple halos around it, and those halos tell you which pollen types are causing allergies. So that's not only useful, but also good fun. So we're putting these methods together to try and directly test, okay, so which pollen types are actually triggering symptoms in people in Hobart. And so the studies involved 70 people and following them over 12 months, logging their symptoms and then doing these skin prick tests and blood tests as well, trying to get at which pollen types matter. And so we run our clinics. You can see Faye here being one of our willing 70 participants, having some blood taken at one of our clinics last year. And we've also collected a whole lot of pollen onto filters over a 12-month period. And then that blood test component involves putting that blood together with the filters and some fancy immunological methods that I'm not going to go into, but basically you end up with all of the pollen on the filters that people, those people that we tested are allergic to, light up with those purple halos. So then you can get someone, in this case will be our fantastic PhD student Lockie, to look down at the filters underneath the microscope, look at and identify which types of pollen have halos, and then we get a really holistic perspective on which types of pollen in the environment are causing problems. So that's the grand plan, and that will give us a really direct and robust answer as to whether this beautiful dodonia flower is actually a nasty allergen out in the community. And look, we had hoped to have the answer by now to be able to tell you, but unfortunately, as with many projects, COVID's put a little bit of a spanner in the works. Lockie was meant to be going to the US to do this work on a Fulbright fellowship, but obviously with COVID, that hasn't been able to happen yet. So you have to stay on tenterhooks for a little while longer. We're hoping to get this work done over the next sort of 6 to 12 months as the situation evolves, and find out once and for all whether those eucalypts and tea hot bush are really causing problems. So I just want to acknowledge the AirRater team, as I said, led by Faye, and there's a whole ream of fantastic people working behind the AirRater app there. And also our stakeholders and funders. AirRater is funded by the Tasmanian Department of Health, ACT Health, NT-EPA. We've also got a lot of stakeholders we work very closely with, including EPA, TAS, CSIRO, TAS Fire Service and the Bureau of Meteorology, and Asthma Australia, and many more actually that we haven't been able to list. It's actually quite hard to make a stakeholder slide for AirRater because we've got so many. And also, as I mentioned before, the Tasmanian Community Fund, I just like to acknowledge is funding the Which Pollen Matters study. So that's me. Please post lots of questions about pollen if you're interested in the Q&A box, and we'll come back to them later. But without further ado, I'll hand over to Anthony, who I believe is going to take us back to the world of bushfire smoke. So thank you, Anthony.
Thanks, Penny. Hi, everybody. So I'll try to share my screen, as Penny mentioned, and give you a little insight into the experiences of consumers during last summer's bushfire disaster. So before starting, thanks Penny and Faye for the great work that you presented to us tonight, but the great work that you do on an ongoing basis with the Menzies Institute, the University of Tasmania and CAR. It's really important relationships like this for Asthma Australia. We task ourselves to taking action and advocating on behalf of people with asthma, improving the environment around them so they can just focus on their health, their well-being, and how to live well with their asthma and achieve their goals. But we know we can't do it alone, and our relationships and partnerships with institutions like these are critical in us being able to achieve our goals. So thanks for the invitation tonight. And also, before starting the presentation, I'd also just like to acknowledge the traditional owners of the lands on which we meet and pay respects to elders past and present, and note that people who identify as Aboriginal experience twice the prevalence of asthma and are twice as likely to experience the negative impacts of asthma than others. So this kind of work for us is critical and very important for us. So yeah, thanks for the invitation. What's making us wheeze, and I guess to be consistent with the title of tonight's event, what's making us sneeze? To contribute to the event, we thought it was pertinent to present the insights and findings of our consumer survey that we conducted over the black summer of bushfires in Australia. So just by way of an introduction, I guess as a peak body for consumers with asthma in Australia, we take the responsibility of providing important health information to people with asthma so that they can best navigate their condition, if you like, and best achieve their goals and live a life unburdened by the perils of asthma. We consider ourselves the voice of people with asthma, and we'd like to respond on their behalf to issues that affect them, issues within the environment, within the system, in their communities, that we know that can be adjusted to provide relief to people with asthma. We observed a period of fires and a period of poor air quality across the eastern seaboard, and particularly around the central New South Wales and the southern part towards and around Sydney from around July, in fact, to the middle of 2019, and increasingly into the summer period where it obviously intensified, which Faye just presented to us. And our modus operandi until that point was, as I said, to enact our responsibility and our role as the provider of resources and information to support people with asthma to maximise their health and minimise their vulnerability in such circumstances. But at a point in December, we got together as a team and sort of kind of threw our papers up in the air and said, God, there's got to be more we can do on behalf of people with asthma than just tell them to stay inside, to keep taking their preventer, to keep their reliever on hand, and to see a doctor if they get sick. Can we stop the bushfires? Well, obviously that wasn't a realistic thing, but is there something else we can do? And so we had a bit of a debate. It was quite animated, to be honest with you. A lot of energy and passion within the team to do more than what we felt that we were doing at the time. And at that time, we were also provoked by a consumer story that was shared with us by a generous consumer who lived in the Hawkesbury area, and she said that she just returned home after spending a couple of months in hospital after a severe asthma attack, which was provoked by poor air quality and exposure to poor air quality during hazard reduction period, and felt disappointing with the air quality produced by the bushfires. She talked about all of the all of the expenses and the impact that a prolonged admission to hospital had on her life, but also that how hard it was to enact all of the public health recommendations that we were providing consumers and authorities were providing consumers at the time to take action to avoid exposure. Stay inside, run your air conditioner on recirculate if you've got that function, etc., etc. All things that are easier for those that have perhaps the means compared to those that perhaps struggle to have the means to be able to do those things. So it kind of reinforced some information that we were aware of about the widespread burden of such an experience on people with asthma, and it gave us pause to really think about what we could inquire about and investigate with a properly constructed survey. So to set the context and I guess to add to Faye's presentation, which described the context much more richly, I think, in regards to how bad air quality was over a period of time. But this is just a graphic indicating air quality ratings in Sydney between 2019 and 2020. And you'll see that in 2000, there was only 1 year in that 11-year period where air quality was poor or worse for at least 50 days. Whereby in the disastrous Black Summer period between November and January, on more than 100 occasions, somewhere in Sydney, air quality exceeded the hazardous threshold, and on more than 6 occasions, on 6 occasions it exceeded a measurement of 2,500, which was more than 6 times the hazardous rating. So things were bad, obviously, and as Faye said, the impact on people with asthma is clear. It's almost uniform, and it can be very severe. So, as I said, we undertook to complete a survey of our consumer stakeholder base, as well as broader consumer base outside those that are typically engaged with us, to better understand the extent of the impact that the Black Summer bushfires were having on our people, if you like, and also the breadth of the impact that it was having. The aim was to, as I said, to describe the lived experience. In our efforts to give voice to people with asthma and act on their behalf, the best way to do that is to share their story directly. There's no better way, and there's no more relevant way. We wanted to also raise the awareness amongst our wider stakeholder network of the community vulnerability and advocate for tangible actions to address and reduce this vulnerability. And as we task ourselves to provide important, timely, meaningful, consumer-tailored information to our consumer stakeholders who do come to us for information, we felt it was important to stay abreast of the changing climate, of their experiences as time passed throughout the bushfire period, so that we tailored our messages accordingly. We undertook a quantitative and qualitative survey design. I think it was approximately 30 questions. It took about 12 to 15 minutes to complete. It was open to stakeholders for 6 weeks from the 19th of December until the 30th of January. And it was promoted to our stakeholder database, as well as the wider community using various social media channels, and a couple of our stakeholder partners or partner stakeholder organisations facilitated, enabled promotion of the survey. Given the importance of the survey, what we were trying to achieve with it, and how well we wanted to interrogate the findings, we worked with Dr. Sharon Davis from the University of Sydney, Dr. Din Buey from the University of Melbourne. He was supervised or supported by Professor Shamali Damaj, also from the University of Melbourne, and Amy Chan, a young research professional from the University of Auckland, also reached out, and we worked with her on the analysis of the findings. So what did we learn? We got responses from 12,000 people over that time. That was an overwhelming message in itself on how important this issue was, that people felt like they wanted to lend their voice to. 61% of people who did respond were people who said they had a doctor diagnosis of asthma, which is not surprising that the majority were. But what was not encouraging, what was surprising, was that almost 40% of people who responded didn't have a known diagnosis of asthma, but were so affected, so impacted, and so motivated to provide their voice and provide their feedback that they participated. So it was important to get the experiences of a substantial proportion of both people with asthma and those without during the survey, which we didn't anticipate. As I think consistent with Faye's diagram around which areas of Australia were affected, as that describes the proportion of respondents from which state in which states of Australia. So the key findings. We had a look at the results. We spent a lot of time dissecting them, putting them through programs and so on, and doing analyses and summarising them. And we distilled them into 6 themes, if you like. The first one and the most obvious one is how widely the bushfire smoke impacted people. So 95%, and quite clearly it was significant, 95% of people with asthma reported experiencing asthma symptoms. 70% of people that didn't divulge a diagnosis of asthma said that they experienced one of the 4 symptoms of asthma that we included in the questionnaire: cough, wheeze, shortness of breath, or chest tightness. Unsurprisingly, 4 times as many people with asthma were likely to reported attending an emergency department than those that don't have asthma, and people with asthma were 7 times more likely to report needing to use systemic corticosteroids. Theme number 2 was the finding of how it impacted children and young people. So children and young people below 17 years were twice as likely to report, or their parents on their behalf, attending an emergency department, yet interestingly were less likely to report experiencing symptoms compared to the age group over 17 years. And 43% of children aged up to 17 years, their parents reported them needing to be absent from work or school on at least one occasion. We asked a question about people's experiences in regards to how it impacted them beyond the medical or health impact, the direct physical health impact. It was an open-ended question. It was a question we didn't set up to quantify. And it was overwhelming, the number of responses that obviously told a story of the emotional, mental, psychological impact that bushfires had. A couple of quotes include, "I've been on edge, unable to exercise, which increased my anxiety. I sometimes feel useless seeing how other people seem to be able to function normally when I'm struggling to do basic tasks." People responded despairingly, extremely anxious, in desperation. It painted such a clear picture that it clearly drove one of the policy recommendations that we arrived at, which I'll come to soon. We also undertook to understand the broader, if you like, burden, the impact or the burden on people's lives as a result of exposure to bushfire smoke. People with asthma were significantly more impacted, both in all ways, physically, financially, socially, emotionally, compared to people without asthma. And 2/3 of people with asthma reported that they had reduced capacity to participate in daily activities. People with asthma are twice as likely to experience financial stress. So part of our examination on the burden that the bushfire exacted on people was understanding whether they faced unbudgeted financial pressures. So 25% of people with asthma reported experiencing financial stress. And 13% of people that didn't report having a diagnosis of asthma experienced financial stress. And a lot of people, 1 in 10 people, reported lost salary during the bushfire crisis for one reason or another. Some people reported not being able to take action to protect their health due to the expense or due to the cost or the financial pressures that they're experiencing. And this was a very challenging and confronting finding for us to understand. People who indicated that they took action, evasive action, protective action, before or as a result of the messaging from the bushfires, Also, it seemed to report in greater numbers or experienced a high likelihood to experience medical and health impact, as well as the increasing burden on their overall lives, compared to people who didn't indicate that they took such evasive and protective measures. So those protective measures variously and amongst all of them included staying inside with doors and windows shut, using face masks when in environments engulfed by smoke, using air conditioners with recycled or recirculate setting, and using air cleaners in enclosed or discrete spaces, air cleaners with HEPA filters. As I said, people who took steps to minimise the smoke impact, these steps and others, were more likely to report respiratory symptoms. That included people who reported that they were using their preventer, their asthma preventer daily, more frequently than those that weren't. There are obviously significant limitations in the nature of the survey, and there's probably some that serves to explain this quirky or this nuanced outcome. And it also probably intuitively tells us that people with unstable asthma, people who felt more vulnerable during season and as the season worsened, were more likely to take these measures than others, and also therefore more likely to experience the negative impacts of the poor air quality. But it's certainly an outcome that we wanted to explore a bit more. So a couple of more quotes just to demonstrate and indicate the impact that this period had on people. Even working in a shopping centre gave me no relief, as the smoke could still be smelt inside. It has been near impossible to avoid. And some of our messaging over the season talked about finding safe refuge in public spaces, in shopping centres, libraries, places that we understood to be air conditioned and safer than outside or in other parts of the community. But some people experienced actually that they were also hazardous. Still noticed my son's asthma deteriorate even by staying at home in aircon, because houses are not hermetically sealed. And indeed, that was an issue that was pretty consistent and frequently shared with us. Currently living by myself without a car, so I have to walk everywhere, which means I have to be out in the smoke almost every day, walking to work and walking to get food and other shopping. So, an example of where somebody just doesn't have any choice to protect themselves. So, as I said, the point of doing this survey was to achieve something, to work with government, key influencers, partner organisations like these ones, other key stakeholders, to see what we can change in order to reduce the impact. And I guess to Faye's point, to enable us to live with smoke better and more safely. And a couple of the recommendations and a couple of the projects that we'd like to pursue with partners in collaboration and energetically include the following. In similar vein to the SunSmart approach, an AirSmart campaign, and I think Faye and some colleagues published an article in the Medical Journal of Australia that first spoke of an AirSmart concept. AirSmart aims to improve the environmental health literacy of people across Australia, as they should anticipate facing experiences like the one we just had, hopefully not as severe, but frequently into the future. And combined with important health messages about what actions people can take to protect themselves and protect each other. Obviously, we know that there's no silver bullet, so information and providing meaningful information, accurate information, timely information, and information that's relevant to a person where they are, wherever they are in Australia, gives people the opportunity to take the action that they think is warranted to protect themselves and their families. Building standards obviously were an issue given the porousness of buildings that were reported to us, but also in regards to the proximity of habitats close to environments that are likely to burn, and the reconstruction of communities after last summer's disaster to try to take heed around fire safety standards and the like, including accreditation schemes. Air quality framework for institutions. Parents regularly, they'd call us, they responded in the surveys, talked about their fears around how inequipped and ill-equipped schools were to provide any kind of reassurances about the safety of students in their environments. Help with the burdens that people experience and the challenges that they face accessing the equipment sometimes that could save their life or significantly reduce their impact, but which cost more than they can afford. The establishment of evidence and the building of evidence around the role of face masks in times like this, and especially thinking around the role of face masks for children, and reflecting on that unfortunate scenario of evacuation of populations from Malakuta, whereby people who couldn't board the evacuation craft couldn't be evacuated in the first stream of evacuees, and how could we mobilise equipment and resources to help protect those people. People need support, and telehealth seems a good way to do it, and it seemed to be an effective way that we're able to provide resources and information to people throughout the crisis. And importantly, funding, and not just funding, but a comprehensive, robust, accountable, a reliable provision of mental health care and support for people who experience significant trauma during such crises. So as Faye mentioned, I think we'll go into questions soon. Apologies if I've gone over time, but thanks for the opportunity again. And I think I'm introducing Penny.
Thank you. Thanks, Anthony, and thanks to everyone for speaking today. So I think it's over to Q&A now. So let's see if I can actually work this Q&A function. Excellent. All right, so we've got a first question here from Erin Dunn, saying it will be interesting to see if there are any changes in reported health outcomes during the current period of COVID lockdown, with more time spent indoors and mandatory mask wearing in Melbourne. Faye, that's probably an question for you, I think. Do you want to have a go at that?
Yes, and I agree. It will be interesting, and it would. I'm not really going to speculate because there's so many unknowns in all that, but a lot of those factors that you mentioned are important. And COVID is rearing its ugly head again, and poor air quality comes through winter. So there's other interactions with risk of getting infections is greater when the air is smoky. So there's lots of issues and concerns. So it could be protective. Our responses to COVID can protect us. If we live in a smoky wood heater impacted area, we could be more at risk for when the infection's around. So a lot of people will be watching this space very carefully.
Great, thank you. Our next question is which content of the dust can trigger allergy and respiratory disease? So in most part, it's the dust mites that are in the dust that people respond to, and it really is quite a common. If you go, present to a doctor with allergies or allergic asthma, that's typically one of the first things they'll test for. And so for a lot of people, particularly with not so much seasonal allergies, but perennial or year-round allergies, dust mite is often one of the culprits. So I was actually going to include a slide with a picture of a dust mite on it, but that got lost in the end. So never mind. That's the answer to that one. We've got a question here as well. Is there any work being done on microscopic imaging of pollen sample media and machine learning on images to automate pollen counting? Now, that's a great question. And to be honest, quite a lot of talks I give on pollen, someone asks this, because at the moment, the way that we do pollen counting is actually 1950s technology, and it's very time consuming. It's actually really expensive as well, which is one of the reasons we have air quality monitoring stations. Air quality monitoring stations are automated. The good ones are still expensive, but basically you should be able to set them up and run, and away they go, and they count pretty much in real time. Pollen, the way that we do it is actually by, we've got these pollen traps called Burkhardt monitors that suck in air onto a sticky microscope slide. And so everything in the air, including pollen, but not only pollen, sticks onto that microscope slide. Then we have to pay someone to go and collect that slide out of the trap, look at it down under a microscope, and identify and count the number of different types of pollen they are. So that's, because that's labour intensive, it's time consuming, it means we can't do as much pollen monitoring as we can air quality. So, excuse me, I'm just going to plug my computer in before it dies on me. Yes, indeed, lots of people around the world are working on trying to automate pollen monitoring. And there has been some progress using technologies such as fluorescence combined with laser imaging and image recognition, things like that. So there has been some progress. There's a couple of particularly promising models coming out of Europe, but unfortunately they're still ridiculously expensive, and also they're not at the stage where they're off the shelf and ready to use. They cost sort of 250,000 euros, and you still have to do all of the calibration and set up yourself. It's definitely kind of early adopter stage technology, not something, if you just want to do pollen monitoring and for public health purposes, it's not quite ready to go yet. I keep saying in about 5 years we'll be there. Maybe in 5 years we'll still be saying that, but people are certainly working on it. So that's a really, really good question. All right. Got another pollen question, so I'm sorry you'll have to keep listening to me. Question for me: over the past month, there have been over 4 single-day peaks, 100 to 200 grains per metre cubed in pollen, mainly cypress. I think the latest was yesterday. These look anomalous. Can I indicate why they only last for about a day and confirm that they are indeed real? I can certainly confirm that they're real. I have looked at a few of the slides lately, and there certainly are. And look, that's actually quite common too, to be seeing that degree of cypress pollen at this time in Tassie. We do see that every year. July, early to mid-July is when we see cypress starting to kick off. And so we do start to see those sorts of counts on a reasonably regular basis from now with cypress, probably right up until September, and other pollen types start to kick in around then as well. In terms of the timing, absolutely, it can vary a lot from day to day. That's mostly weather related as well. So, for example, wind direction, but also wind speed. So it will depend on where the wind's coming from, so what type of vegetation is in that particular direction, and also the wind speed, as well as probably complexities in terms of there's different types of cypresses around, and they'll all release their pollen, different species, and also, depending on how sunny your location is, different plants will release their pollen at slightly different times. But I'd say on a day-to-day basis, that kind of fluctuation in pollen levels is mainly a weather-related trend. And that goes for other types of pollen as well. For example, in the grass pollen season, up in Victoria, they've developed a pollen forecasting model for thunderstorm asthma, and that's mainly a weather-driven forecasting model. We've got a question probably from Faye, I suspect, for Faye, I suspect. Is the advice to stay inside during smoke events very effective, or does indoor air track outdoors, sometimes even worse indoors?
Thanks, John. That's a great question. And also, I need to confess, I accidentally deleted another air quality question earlier while Anthony was talking. I didn't mean to, so I might answer both questions if that's but first to John's question about indoor versus outdoor air. Our houses are leaky and we can delay the pollution coming, but we can't stop it. The really fine particles, they're a bit like a gas. They will infiltrate. So if you've got a very short period of smoke from a little burn that ends and you've sealed your house beforehand, you can indeed reduce your exposure quite a lot. If you've got severe smoke that goes on for days or weeks, then it gets harder and harder. And indoor air generally, with a bit of a delay, but generally it will start tracking outdoor air. It might be a bit lower, but not much. So the protection we get from being indoors is a bit ordinary and can be non-existent. And if you don't air out your house after a severe smoke event, smoke can be trapped inside. So really you need a sealed bedroom with an air filter in it if you're going to seriously reduce the amount of air pollution in your home when you're living through a protracted smoke event. And of course there's indoor sources. It can leak in from a heater. Every time you cook with a gas stove, you'll get a big spike in particles even if you can't see smoke in your house. Smoking cigarettes, there's a lot of indoor sources. So indoor air is something we need to take seriously, and that's one of the useful aspects of using an air purifier, because they actually filter out all the sources that are around. The other question was relating to what I said about 80% of the impacts weren't on those super extreme days, they were on the more moderate days. And the question was that simply because there were many, many more days with lower concentrations, and this is across all those areas of Australia. And the answer to that is yes. It was the number of days that added up rather than the shorter periods with the extreme days. So I'm sorry, I deleted your question there. Thanks, Penny.
Cool. Thanks, Faye. And then we've got a last one, probably for Anthony and possibly a little bit for Faye as well, but certainly for Anthony from Julie. What advocacy and actions does Asthma Australia propose in raising awareness of the dangers of wood heater smoke and institutionalised burning off? What current research is available within Australia?
Thanks for the question, Julie. Hard one, you know, and I think you'd probably recognise that. So I think your question, the way it was worded, is raising awareness of the dangers. I think that's one of our roles. It's one of the roles of Asthma Australia to shine a light on the role of wood heater driven air pollution during the periods on people, individual health, on community health, and on the health system. And I believe that the burden on community and the system is greater than traffic and industry combined during the wood heater seasons, at least in certain parts of Australia. So it's an important issue for our stakeholders, the consumers that speak to us, and we recognise it, and it's something that we're aiming to work up. I think there are ideas around trying to get into the conversation around new construction and what options, regulations around new construction and the choice of heaters and so on. There's an important, simple and important effort to be made in regards to standards. I believe that the standards of the wood heaters, the commercial wood heaters that are available, and that they actually they do what they say they do. They emit what they say they emit and emit, and that those emissions are, within regulation. And there's a big role on public education, not only in regards to the choices that people make around how they heat their homes, but as well as the way, if they do choose to burn, how they go about burning and what they can do to minimise the emissions. But definitely, look, it's an area that's important for us, an area that we're working up at the moment. We're looking to collaborate on and think that we have an important role to play and a voice to share on behalf of people with asthma, wood heaters. Faye, do you want to round out the wood heater question before we get into the institutionalised burning?
Sure, I can make some comments on some research that has been done by our group here in Tasmania and also by other groups in Sydney. One of them Anthony alluded to was the CSIRO with University of Sydney and the Centre for Air Pollution Research got together and worked out the sources of different particle air pollution in Sydney, from traffic, from wood heaters, from bushfires, from dust, from all sorts of things, and worked out similar to the work I showed, the health impacts of the different sources. And the most amazing thing, if you looked at the deaths attributable to air pollution in Sydney by source, the one that was responsible for the greatest health impacts was actually wood heaters, not traffic. You've got 5 million people, most of them own a car or two, and I think it's only around 6 or 7% who might own a wood heater, but wood heaters are just so polluting that number of wood heaters can outdo the traffic when it comes to pollution. So that was a very salient way of illustrating. And Nico, who did the work I presented, has also done similar work for Tasmania, and again showed a really disproportionate impact. And the reason is wood heaters might have standards, but it's possible to override them. You can take a perfectly good heater that meets the standards and you can cause incredible pollution. And it takes a bit of skill. Some people can burn well with minimal pollution, but that's actually quite hard, and it's just not universally done. When humans are involved, we need technology that will burn biomass efficiently, and such technology exists. It's just more expensive. Pellet stoves, stoves with 2 combustion chambers, so the ingredients of smoke get combusted before they get vented and cause a lot of pollution. But when we're relying on people to light a good fire in our existing heaters, there's a lot of room for error. And when they pollute and smoulder, and often you don't realise that when you're inside, you've actually got to go out and look at your chimney, but you shouldn't really be able to see smoke pouring out of chimneys, and you just need to walk around Hobart and you can't miss it.
All right. Well, thank you, everyone. That's all of our questions, and we're I'm about to say we're bang on time. We're 1 minute over the 7:15 time, so we'll wrap up there. Thank you very much, everyone, for joining. Really, really appreciate everyone's time in joining us tonight. We hope you've learnt a few things and enjoyed the session tonight. So we'll close up now. Fiona will put up a closing screen. As she mentioned, there will be a survey at the end to fill out. So if you do have any feedback as to how we can improve how we do these online talks, we'd love to hear from you. So thank you very much again, and good night.
Thanks, folks.
Right, thank you.